Hello, everybody. Welcome to the European Public Health Webinar series. Happy European Public Health Week, as well as happy EU Diversity Month. My name is Saida Mäki-Penttilä, and I'm working here at the Finnish Health and Welfare Institute at the Cultural Diversity team. Our team's work focuses on the crossroads and the cross-cutting sections of health and welfare and cultural diversity. I have the great honor of moderating today's second webinar running up to the 18th European Public Health Conference that will be held in Helsinki in November 2025. Today's webinar is titled Participatory Research Action Towards Inclusive and Ethical Health Policy and Practice. We have a great range of speakers lined up for you today. We have Natalia Skogberg from Finland, Sonia Diaz from Portugal, Sari-Anna Alrus and Karolina Himanen from Finland, as well as Niilo Rahko and Donald Warren from the United States. The webinar is organized by the Finnish Institute for Health and Welfare, the Society of Social Medicine in Finland, and the European Public Health Migrant section. And it is co-funded by the Asylum, Migration and Integration Fund, AMIF. A couple of housekeeping rules for today. The participants will have your cameras and microphones on mute for the duration of the webinar. You may ask questions or share comments in the chat, and the chat you can find if you look at the top of the window. There is a speech bubble about in the middle of your screen, which you can press and access the chat. I will be picking a couple of questions for each speaker after every two presentations. And please note that the chat is not anonymous and everybody will be able to see your questions and your comments. And finally, we will be recording this webinar, and the recording will be shared on the European Public Health website. Great. Well, it's nice to see many of you online, and let's move on to our program. I would like to welcome Chief Researcher Natalia Skogberg from THL, who will present on Finland's experiences in translating research into practice and policy. Welcome, Natalia.
Thank you, Saida. It's a pleasure to be here, and hi to everyone. So I will be talking from the perspective of Finland, and especially the Finnish Institute for Health and Welfare, THL's Cultural Diversity team, where we have 32 experts working with migration, ethnicity, and health. And we focus especially on research and development that aims for high societal impact and mainstreaming cultural diversity. So I'm talking now especially about translating research into practice and policy and our experiences, because I think that is our strength in our team. And the reason why this topic is important is because research alone, it does not change life, practice and policy does. So we have been building a really strong research base since 2010 in Finland on the health, well-being and service use of migrants and minority ethnic groups. And this is very broadly used by policymakers and practitioners. We have broad collaborations with many ministries and also with health sector. So what are our lessons learned from effective translation of research into practice and policy? First of all, we have to think about why are we producing this knowledge? Is it just because it's nice to know, or is it something that's actually really needed for practice and policy? It's imperative to do co-design with all relevant stakeholders, including the populations who we aim to serve, practitioners and policymakers, It serves all towards building trust, meeting the actual needs, and this all ensures feasibility and sustainability of the developed practice and policy measures. The most simple way to ensure effective translation of research into practice and policy is to embed it into the project life course. And then the next 3 points are something that I will go a little bit more into detail about with some case examples from Finland. So these are keeping the big picture in mind, even though you're dependent on individually funded projects, as we are also in our team. Making use of policy windows and timing, so being at the right place at the right time and taking advantage of that, and then communication and dissemination. So let's start with keeping the big picture in mind. Here on the left, you can see type 2 diabetes results that we got in 2012 in our population-based study. And there we noticed that, okay, the Somali origin population has a high prevalence of type 2 diabetes, and then also women of Kurdish origin compared to the general Finnish population. Then we did many studies, in-depth studies on why this is and how it's related to different background factors. Another team at THL used this information as a nugget to develop a culturally sensitive lifestyle information. So they did the translation into practice. But then this work was put on hold because COVID came. And then a lot of our attention, most of our energy went into working with COVID, as many other researchers. And we worked, for example, on looking at the incidence of COVID, looking at vaccine uptake, the psychosocial impact on the migrant populations. And then at the same time, we were using this research to apply it in practice. So to develop practical community-based measures on how to reduce the incidence of COVID and how to increase the vaccine uptake among migrant populations. And we especially developed our skills in building inclusive and accessible communications, further strengthened our work in co-design and community outreach. And COVID was a really important example for us in Finland and for, I guess, everyone else to see that when there's a will, there's a way. So mainstreaming cultural and ethnic diversity is actually possible when there's a will to do it. And we packaged these experiences into a policy and a practice report on supporting persons of migrant origin in serious disruptions and emergencies. And then a new opportunity came along through external funding, and this was Jakarta, and this project is currently ongoing. It's a massive EU project that strongly links with practice and policy, and it involves over 70 partners from 21 different countries, and it has 142 sub-projects. So you can imagine the impact is massive. So in this project, our team at THL actually draws from the experiences on COVID-19 strongly and other experiences that we have had over the past 15 years on mainstreaming cultural and ethnic diversity, developing concrete tools on how to do that in a complex European setting. And then at the same time, we're taking advantage of the information that we have had from 2012 in type 2 diabetes. So actually working on some really concrete projects under Jakarta. One is co-designing culturally appropriate health material for women in maternity clinics to prevent diabetes. So here, two kind of separate topics that we combined together later on. Another point that I wanted to make is seize the momentum, so policy windows and timing. So here are results that we have been gathering for, again, almost 15 years now on experience of discrimination. And we know that these experiences are highly prevalent. We have also researched this in a number of in-depth studies, and the infographic below it's in Finnish, but it depicts how discrimination impacts the life course. So this was a palatable way for practitioners, decision makers to understand the impact of discrimination. Then we translated these research findings into practice by co-designing an online anti-racism course for professionals, and then an anti-racism capacity building project that's currently ongoing, where we have 27 organizations outside of THL that are developing anti-racism structures within their organization with our support. And then also a window of opportunity came through a huge media scandal, which maybe you have also noted. It was a couple of summers ago with the Finnish far-right finance minister being accused of racist online comments. And this one actually was really picked up by the media. It got a lot of attention. Our experts were broadly invited to many TV interviews and newspaper interviews to provide expertise and to share all the knowledge base that we have accumulated on discrimination and how it impacts life and what we can do about it. So all this media attention, which was also supported by our experts, it led the government to launch a campaign, action, not only words. And our experts were very much involved in developing this campaign as well. And as a cherry on top, also our own institution, which has over 1,000 persons, also committed to make some concrete measures how to fight against racism, which was really great, of course, a great achievement for us. And then the last point that I want to make is don't wait to be discovered. You have a voice, so use it. So I think as researchers, it's our social responsibility to make our research visible, to translate it into practice and policy. And how to do that? Some of our experience is not being only reactive, so just waiting that we are invited somewhere, some policymaker asks us, but also providing some strategic trainings, being visible, using our voice. Another way of being visible is holding regular events. So for example, we have 2-day Monet seminars every year where we gather professionals, policymakers, and researchers, and the NGO sector as well. Stakeholder engagement at all phases continues to be important. Of course, it's important to measure impact. Where are you seeing? How does this then change things? And then it's important to consider inclusivity, accessibility, and effectiveness of communications. So what do you want to achieve with your communications? Who holds the power to make a difference? And what kind of information do they need to be convinced? So thank you.
Thank you so much, Natalia, for this quick glimpse into policy and practice and timely action. If you have some questions for Natalia or comments, you can write them into the chat. We will be taking them together after the next presentation. So please feel free to ask your questions in the chat, and I'll choose some from there. Let's move on to the next topic. Professor Sonia Diaz will present about doing research with, not on, and participatory methods in practice. Welcome, Sonia, and you'll be sharing your own slides. Go ahead. Thank you.
Thank you so much for being today here. It's a great pleasure, and thank you for the opportunity to share some of our research, thinking about how to use participatory methods in research, but also in co-design of more effective interventions. So this is just a very quick reflection, and we know already that there is a huge gap between knowledge producers and studied populations, and it's really difficult to overcome this specific issue. And so there is almost a paradox, because what we know is that the health strategies adopted most of the time are not very adequate to most of vulnerable communities or addressing their real needs. So what we see most frequently is that the greater vulnerabilities that some of the groups face and are normally huge, and these groups are frequently underserved or understudied. And so what we know is that policies and interventions that are organized to improve population's health, normally they fail to reach or to benefit these type of groups. So what we know already is that we need to rethink directions in research to inform policies and to support the design and implementation of effective practice to also address these vulnerabilities. So about this, we know also that we know to have a shift paradigm in terms of research, but it also implies to the academics to think in different ways of knowing, also trying to understand how can we renew the power dynamics that normally happen between the academics and the populations. So we need to ensure and to find methods to ensure meaningful participation of communities along with researchers in the research process, and also how to find different methods that we could have effective knowledge sharing and co-learning as the key elements to generate new insights in order to work together for a collective action. I will not have time to go through this paper, but we tried to link with other teams that think about this issue, and we make advocacy in order to have a normalized participatory health research approach in the WHO European region for those who experience more vulnerabilities. And one possibility is to try to use different methods of research, like arts-based methods or co-creation of other methods. And that's what I'm going to share very briefly with you today in a project about health literacy development, health promotion, and social cohesion in migrant populations. In fact, this is a project recognized by the WHO as a National Health Literacy Demonstration Project for non-communicable diseases. You have here a paper where we describe in more detail the protocol and the application of the Ophelia process. And very briefly, our project has three main phases. One is more needs assessment, but it's quite interesting to understand that we didn't use a deficit approach. In fact, we tried to understand what was the needs assessment, but we were also looking for the strengths that community has, and that take that opportunity to use and to enlarge the strengths of the community to promote better health interventions. So we used a survey, and it was quite interesting because we worked together with the community leaders and migrants as the community researchers in this survey. I will not have time to go through that. But then we also use a qualitative mixed method study using qualitative methods also, and a photo voice that it was interesting, and I will explore a little bit later. Then we have a second phase, it's a co-design health literacy interventions. And then at the moment we are now implementing and trying to evaluate, even in the evaluation, we are using a participatory approach. So in terms of the first phase of needs assessment, we used the health literacy questionnaire, and the way that we looked to the data, it was quite interesting because we were not only trying to see what is the average or trying to classify people in terms of low, average, or high level of health literacy. We were more interested in identifying subgroups of individuals who have similar patterns. And indeed, this kind of approach, and I will show you now, we use the cluster analysis, but this show us different profiles, not only with the health needs, but also with the resources that community has, trying to understand what kind of dimensions they are already very well, so we don't need to continue producing interventions for that. And what I would like to highlight today is that because we want to work with the communities and to work also with them in trying to understand the data and contextualize and identifying the main message of the data, what we have done is that after after we have these health literacy profiles, we worked with them trying to find and develop vignettes. So because we also have the social demographic characteristics, we here you can see we develop vignettes with the profiles, and we worked with migrants to represent a case with a context of someone that could be migrant in Portugal, and also with situations that represent the needs, but also the strengths they have in the different dimensions. Then we use these vignettes in other phases that I would like to explore. So also, like I was mentioning, we want to ensure that we would include those who normally are underrepresented in the research. So we try to use photo voice as a method to include those who has less literacy or less capacity of replying to a questionnaire, or at least they have difficulties expressing themselves in Portuguese or in English. So we use a photo voice with 18 migrants, and it was quite interesting because we used these photos and the stories behind these photos in a virtual exhibition in a room that the mayor of Lisbon organized for us, and the migrants themselves worked together with us to organize this exposition. Then, based on the data that we have collected, we were able to co-design and to organize 10 idea generation workshops with healthcare workers and managers, social care and community workers, but also with migrants. And it was quite interesting because we worked from the beginning with these stakeholders, and even more with migrants, and some of them experienced social and economic vulnerabilities. But at this moment in the project, they were very interested in being very active. So most of the migrant workshops were also organized with them and by them. So it was quite interesting. So in these workshops, in the beginning, we started to present the vignettes, and it was quite an interesting way of introducing the data and presenting the data found, but in a different way, where it was very clear for all the the participants of the workshops. And then we started to questions like, do you know people with these characteristics in your communities? And this was also for health professionals and migrants and social workers and others. And then we try to understand what kind of problems do you see that this person has in the field? What kind of resources can we use to strengthen the capacity of replying to their real needs? And also, what possible actions do you would like to implement for and with these people? And it was quite interesting to see that at the end we found more than 70 ideas, and most of them was they were really what we can call low-cost interventions, very simple to implement, but with a huge impact in their changing people's lives. So there is also lessons learned for the academics that we could bring when we use participatory approach. And this is something that I would like to highlight to finalize my presentation. But in fact, what we have learned is that participatory health research, it's a very good way of collecting knowledge production, very useful for replying to real needs of populations, and particularly those who experience more vulnerabilities. Normally, the research and the data are more culturally adapted. Also, we could create trust and credibility of the studies by with all partners, and our data much more informed about the factors that are influencing health, but also more comprehensively understanding the human actions, their determinants and dynamics, the root cause of behaviors, and understanding from the perspective of those who really need to work with the barriers and facilitators. And also the same for not only the research part of collecting data, but also the research part regarding the co-creation approaches for evidence-based health policies and practice, and the community's engagement really help us to develop more effective health promoting interventions. The design context were much more appropriate and acceptable. And like I was mentioning, it was really interesting for us to understand the practice that they were informing us to develop was much more low cost and simple to implement. And with that, we were able to bridge the gap between knowledge, action, and in fact, it really impacts in the population's health. Thank you so much for your attention.
Thank you so much, Sonia, for that and showing us the new ways of knowing. Maybe Natalia, if you could join Sonia with your camera, and then we can take some questions for the both of you. I urged you attendees to write some questions in the chat or some thoughts. But meanwhile, I thought this new ways of knowing was interesting, and perhaps both of you could share how it looks like from your position as you both navigate research institutions, and there are some traditions. So how does bringing these new ways of knowing or new ways of doing research show up in your work? Either or can start.
Well, I think the co-design perspective has been building strength over the past few years, especially in our team's work, and I think in Finland as well. And the methods that Sonia presented, the Ophelia methodology, it's a really great example of how you can do the co-design meaningfully without tokenism, because I think even though there are many attempts in applying co-design perspectives, then it can remain at quite superficial tokenistic level.
Yes, I totally agree. And at least from our perspective, more and more we are talking about using participatory approaches and co-design, but in fact, we really need to work on that also from the academic field, because most of the time, like you were mentioning in your question, academics are not really prepared to share, for example, power. And this was what we were trying to reflect in the paper that I presented, that if we really want to work in a participatory way, we have to we academics, we have to be prepared to share knowledge and to understand that probably we have the different parts of the project has different types of knowledge, but we cannot say that this knowledge is more important than the other, and so we have to respect the different knowledge and to ensure that if we, and I think this is the most important part, that if we respect and use the different types of knowledge, we probably will end up with a project much more adequate and more prepared to reply to the different and to respond to the different needs. But this, like you were mentioning, this needs some paradigm shift. In academic field, for example, in institutions, for example, being able to share the budget, that's something that it's normally quite difficult. But also, for example, for the scientific journals, they have to be prepared to accept different papers and more about the process of using this type of methods and reflecting the advantage and disadvantage of these methodologies. It's a huge field of research that, of course, we don't have time to go into detail, but we have a lot of advantage of using participatory methods, but normally I tend to say that it's not really an easy process. So we are learning more and more how to do it, and how to adapt the field of research to be able to take and maximize the advantage. But for example, the time that we need to use participatory methods, it's really different from those who normally we have when the research is only research driven. So this is some points that we have to continue working. It's quite challenging, but at least from what we have learned from the different projects of participatory health, it really makes the effort because the results are much, much better.
Thank you, Sonia. And maybe, Natalia, just to ask you a little bit more about the stakeholders that you had in the processes of both the Jakarta as well as the COVID work. Could you talk about how did you engage stakeholders in the process of translating the research into real world impact or practical impact? Do you have an example of that?
Well, in Jakarta, for example, the maternity clinics are involved, so the professionals are involved, and then also NGOs, and then through NGOs, women of migrant origin were also recruited. So that process is ongoing at the moment. So the interviews are actually going to be held in the autumn. With migrant origin women and some observations as well. And during COVID, for example, there were multiple roundtables which we held with NGOs and key community representatives. We also had roundtables with professionals. So keeping the discussion and then having the persons invited generate, tell us what is needed, what kind of information is needed, what should we be doing. So kind of being the experts of not knowing. So what Sonia mentioned, like stepping back from the researcher or expert role and giving it to others, because the ones who know better what they need.
Well, thank you, Natalia and Sonia. Unfortunately, our time is telling us to move on to our next presentation. But if you do have any more comments, you can write them in the chat. And our next presentation is prepared by public health nurses, Sarianna and Karolina. And today, Karolina will be presenting on advancing inclusivity, bridging the gap between research and practice in healthcare. Please, well, you're welcome, Karolina. And you can use the clicker right here.
Okay. Thank you. Okay, so I'm Karolina Himanen and also a midwife nurse and a MA in health sciences as well, and speaking on behalf of Sarianna as well today. And we are from the welfare area in Vantaa and Kerava in Finland, and our work is in the health services supporting integration. And what we are talking about today is how we use evidence-based information from studies in our practice, in our work every day. We have this combined social and health services unit in Vantaa and Kerava area. We have about 40 multi-professionals working there. We do support for refugees and their family reunifications, victims of human trafficking and unattended minors. And our goal in our work is to remove obstacles to enable work and study for our clients and support agency and inclusion to society. And we have developed and continue to develop our services based on THL studies such as Moni-Suomi study and as well as other published research and data and literature. And we have a few examples of our work. So I will go through those briefly with you. So as we know, the access and use of healthcare services can be challenging for people with immigration backgrounds. There are some structural barriers. For example, digital services, automatic messages, and callback services can be challenging for people who are new to our systems in Finland and who do not know Finnish or Swedish or English. So we've created materials for easier access for these groups. We've created printable pictures and instructions on how to find several different services, for example, health centers, laboratories, X-ray units, and many others. We also have these same pictures and instructions in digital files that can be shared via different message apps and sent to clients we can't meet. For that day, for example, we can, for example, call them and then send messages after the call, after the contact. We've taken several photos of places that are somehow important to the people so they can find their way, for example, to a laboratory or healthcare. And that's how we do that. And here are some examples of those. So what these accessible materials ensure is that our diagnoses are based on correct information, that our treatment plans for our clients are implementable, and that our medical treatment we give our clients are correct and safe. Here are a few examples again of the forms we've created. Here is an example of blood sugar measurements at home, blood pressure measurements at home, and then the third one is headache diary monitoring to do at home. And this is how we ensure that also our patients who may be illiterate in any languages can do these monitorings at home safely, and that the information they give us is correct. We also use color coding and photos to make sure that people understand what they are supposed to do. Yes. Okay, then our counseling is based on individual life situations and evidence-based information as well. As we know, economic challenges are a reality among many migrants in Finland, and these challenges can often be stigmatized as well, and they are not easy for people to talk about, even when meeting with professionals. So the lifestyle counseling must be also based on individual social economical situations. And that's what we have done. We have created materials to be inclusive to all our clients. And for example, in this picture you see here, we've chosen products that are affordable to all and are easy to find from local grocery stores everywhere in Finland. And just to mention that these pictures are not chosen for any marketing purposes. We do not get any profit from marketing any specific products. It's only to help our clients. So how to support agency inclusion and informed decision making for our clients? Well, we need to achieve health equality, and that is what we strive to do in our services. We use interpretation in healthcare services because it is well known that lack of common language creates barriers in the healthcare services. We use cultural competence and cultural sensitivity in our basic work. And then we also take into consideration health literacy. It is not the same for everyone who comes from different backgrounds, and we need to address that when giving counseling and supporting our patients. And so the use of pictures creates comprehension for our clients who are not fluently health literate in their lives. As known, psychological symptoms are essential health challenge among the migrant populations as well. And that's why we've created our own questionnaire and modified it to address all these issues arising from various studies. For example, traumatic events in life, addressing also racism and discrimination and lack of inclusion in society and all the social and healthcare services and other services as well. The misuse of substances, gambling, and social and economical challenges. And also, as I already mentioned, stigma prevents many people from asking help for these kind of sensitive issues. And also the lack of proficiency prevents professionals to recognize these challenges, why these sort of structured questionnaires are a good way to go about these things. Here are our references. You can look into those if you want to, and thank you.
Thank you. Thank you very much, Karoliina. I'll just come here so everybody can hear us. We will take your questions as well, just like previously after the next presentation. So thank you so much for that. And all the pictures also in your presentation. Up next, we will move on to looking at Niila Rahko's presentation. Unfortunately, he's not able to be live today with us, but his presentation will focus on ethical collaboration in Indigenous research, strengthening well-being and participation in Sami. And Sami is Europe's indigenous population. So let's go ahead and see what Niila has to say.
Dear audience, it's an honor to speak here today about ethical collaboration in Indigenous research with a practical focus on the Sami people and Sápmi, our traditional homeland. I am Alehleme Heikka Ovla Arja Niila, or Rahko Niila, an expert on Sami affairs at Finnish Institute for Health and Welfare, shortened THL. I work in the coordination of the Sami affairs at THL. I am a Sami with North Sami as my native language, and I have a depth knowledge of reindeer herding culture in the Utsjoki area and the significance of Sami traditional knowledge in well-being. The Sami are the only indigenous people recognized within the European Union. They live across 4 countries, Finland, Sweden, Norway, and Russia. Sami society is linguistically and culturally diverse, with its own languages, traditions, and political structures. In Finland, there are around 10,000 Sami, and they are represented by the Sami Parliament, or Samedikki, which has a cultural autonomy. Linda Tuhivai-Smith has said, research is probably one of the dirtiest words in Indigenous world's vocabulary. So historically, research has often served as a tool of colonialism. Sometimes something done to indigenous peoples, not with them. It's time to change the course. Research must be collaborative, ethical, and inclusive. So let's start with the foundations. Ethical principles, or ethics. The cornerstone of the ethical research with indigenous people is FPIC, or as we know it, free, prior, and informed consent. This isn't just a one-time signature, it's an ongoing process. And it applies both community and each individual involved. Research must be community-driven. The best research questions come from within the community and are shaped together with researchers. This ensures relevance and the ownership. Cultural safety is equally important. Research must learn about and respect Sami languages, traditions, and worldviews. This includes understanding what knowledge can be shared and which is sacred. Knowledge return is a responsibility. Results should never sit on university shelf. They must be returned in ways that are understandable, accessible, and ideally in Sami languages. And they should be returned to the Sami people or communities that have been within the research. And at the heart is self-determination. Sami people should not only be involved, they should be led or co-led research about their own communities. The care principles help guide this work: collective benefit, authority to control, responsibility, and ethics. Together, these principles ensure that the research contributes to the well-being of people it concerns. So how can we put these principles into practice? Let's start by building relationships. Trust doesn't happen overnight. It makes time, presence, and genuine dialogue. Listen actively. Make space for Sami voices, not just the data points, but as experts. That means centering their values, languages, and priorities. You have to respect traditional knowledge. Some knowledge is not meant to be shared or must be handled in culturally appropriate ways. Ask first, respect always. Plan collaboratively from the very beginning. This includes the community in setting goals and deciding on methods. Be transparent, share your intentions, explain your methods, and talk about what you will be doing with the findings. And then finally, return benefits. What will community gain from your work? That might be data, visibility, funding, skills, or simply having their voices heard. To close, collaboration is not just ethical ideal, it makes research better. When we build trust, we access deeper knowledge. When we work together, we create more useful, grounded insights. This is how we move from extraction to empowerment. Decolonization is not a slogan. It's a very everyday choice. It's about our everyday choices. Who benefits from this work or research? Whose voice is heard? Who controls the outcome? So let's build bridges between academia and Sami communities. Bridges built on listening, respect, and shared purpose. Today, for the young researchers who are listening this, I want to say this: research out early, ask questions with humility, and bring community in your work from the very beginning, and build on trust. Together we can create co-research that supports well-being, self-determination, and more just future for all. In my own work as a Sami and a mental health professional, I have seen ethical collaboration that can also be healing. I have witnessed how respectful, inclusive research can promote not only better data, but also greater well-being and trust between researchers and communities. So, what to do? Well, I think that together we can build bridges, not only between academia and indigenous communities, but also between different ways of knowing and being. So, Kiitos, Takka, Spasep, thank you. Thank you that I could be here speaking with you throughout the video, but still speaking with you. I want to leave you this reference list. You can check my info where I got it, and I hope I will hear about you all. Thank you. Kiitos. Takas pääsi.
Thank you very much, Neela, for that presentation and taking us towards Indigenous peoples. Next up, I would like to introduce MD and Professor Donald Warren. I'm really impressed at you being awake at this hour in the Mountain Standard Time, but it will be great to hear from you. And Donald will be presenting on Towards Inclusive Health Policy, Indigenous Perspectives for Equity and Well-Being. And he will center broader Indigenous perspectives. Welcome, Donald.
Thank you so much. Very happy and honored to be a part of these important discussions. And I really appreciate all of the comments that we've heard already. And again, I'm Donald Warren. I'm Oglala Lakota, which is a tribal nation in South Dakota. So I'm connecting in from South Dakota at the moment. And I'm co-director of the Center for Indigenous Health at Johns Hopkins University. And our center works with Indigenous populations, of course, across the United States, but worldwide. We have strong connections with populations in Canada, Australia, and New Zealand. And actually, prior to the pandemic in 2019, I also visited the University of Tromsø, where the Saminor study occurs. And I really appreciate what's happening at THL with more engagement of Sami populations and the work that Neela and others are doing as well. And one of the things that I find really fascinating is the similarities that we see across very diverse Indigenous cultures. And on the left, that's a picture of a Sami family from about 100 years ago in front of their traditional homes. And on the right, this is a Lakota family from where I'm from in South Dakota. And it's not just the dwellings that are similar. There's a lot of similarities in terms of culture and the impact of colonization, loss of traditional food systems, and issues related to climate change, and all kinds of things that are having a similar impact across Indigenous populations worldwide. And I'm really hoping that through our Center for Indigenous Health at Johns Hopkins, we can continue to strengthen our relationship with THL and other groups across Europe to explore ways to improve the way that we conduct research and implement public health programs. From an Indigenous perspective, and certainly from Lakota, where I'm from, we look at things in a very holistic way. And we understand that there's a connection across spiritual, mental, physical, and emotional aspects of who we are as human beings. And in my own training, of course, I'm also a physician and trained in public health and social research. And I think that we tend to really focus on physical health in the modern scientific or academic perspective. But if we're going to effectively engage communities and really pursue the goals of what we're talking about in this webinar, we have to open our minds and really understand that there are other perspectives from a cultural basis that have an impact on lifeways and an impact on the way that people live. So the research paradigms and the policies and practices should reflect local culture. And one way to think about this in terms of the medicine wheel and spiritual, mental, physical, and emotional components is the way we conduct public health programs and even the way we conduct research. And we can think in the East, the spiritual realm is where we envision what we want, including applying this toward even planning and designing research. In the physical realm to the west is where we implement our programs or our research projects. And to the south, the evaluation process, so we can re-evaluate what we are doing. And as we do that, we can see this as a circular process. And Indigenous peoples have been researchers and program designers and evaluators for thousands of years. We just had different terminology and different ways of looking at things. So I really also appreciated Carolina's final slide showing this very similar image of the difference between equality and equity, and realizing that in the equality perspective, we have similar processes. So everyone gets the same research design, or everyone gets the same curriculum within an academic institution. And we do that as kind of a one-size-fits-all approach. And in my own experience in academics in the United States, I've seen a lot of one-size-fits-all approach to the work that we do. But as we've been discussing today, there's such diversity across populations. We need to recognize that if we're going to achieve equity, sometimes our design and our methodologies need to be variables so they can meet the needs of diverse populations. And then even thinking about this image, one question is, why is that fence there in the first place? And when we think about liberation or we think about overcoming systemic barriers, perhaps it's not just the design that needs to change to overcome the barrier. Perhaps part of our barrier is the fact that we don't have enough Indigenous people as principal investigators. So I did participate in a publication, it's cited here, looking at recruiting Indigenous patients into clinical trials, a circle of trust. And I do a lot of work with research and Indigenous populations around the US, but also internationally. And we have to recognize that the community engagement piece is so vitally important. So really appreciated the perspectives from Natalia and Sonia at the beginning to look at how we best engage communities and focus on meeting community needs and co-design of research. There's also the need for trusted entities, whether it's engaging local traditional healers, local elders, or local physicians and other people who are trusted within the community. And then the investigator also needs to be a trusted entity to recruit participants into these studies. And one area where I think we could really make significant improvements is to diversify the principal investigator pools. We need more researchers who are coming from our communities. So again, I'm very excited to see what's happening at THL and in other parts of Europe and how we're seeing improvements in the way that we engage populations, but also look at how we can apply research findings to policy and practice to meet the needs of diverse populations. So I have my email address here. Be happy to connect with anyone following this webinar as well. But there.
Thank you so much, Donald, and thank you for your presentation and bringing us closer and mirroring. It was really interesting to see the Sami and the Lakota tribes similarities in those pictures, and also translating the traditional medicine wheel into the project design language. That was really interesting. And at this point, we will take questions for both Donald and then Karoliina and Sarjan. I don't know if you both want to step out here. We can have a small conversation. But maybe I'll start with you, Donald. It was interesting. It would be interesting to hear, what do you think motivates Indigenous communities to engage in health and social research? What are ways to ensure participation?
Yeah, and one of our big challenges is we have terrible health disparities, and we say that across Indigenous populations worldwide, the impact of colonization, the loss of traditional culture, traditional food systems, and ceremony and language, all of those things have a negative impact on health outcomes. So there is recognition across populations that we need to develop new solutions. And the only way to do that is through a research process. So there are many communities that are wanting to engage in research, but historically there's been distrust with academic institutions and the research community, because I think quite often the research process has been extractive, taking knowledge from the communities without really applying those findings to the communities through policy and practice, like we're talking about here today. So it can be challenging to develop trust in those circumstances. But again, I think that's also why we need more diversity in the research community. We need more Indigenous principal investigators, for example. But I do really admire what you're doing at THL and engaging diverse populations, including the Sami population. I think that there's a lot of room for continued collaboration and making sure that we're doing this work in a culturally relevant manner.
Thank you. And then maybe, Karoliina, I'll ask you, since you're using the research and then taking more to the practical level again. So now that the population study Monisuami is going to be, it's a big population study done in Finland on foreign-born populations, will be conducted again in 2027. What questions would you like to see there that would help you with your practical work?
Well, as a midwife, always, and an expert on FGM, which is a female genital mutilation, I always like to see more sexual and reproductive health issues, especially among migrants and minorities in Finland. So that is my
Great. And then you both had the same kind of, Donald, you didn't have it at the end, but the slide on equality, equity, and liberation. I don't know if you had any, since you didn't really get to go through that slide, did you have something that you would like to comment on what Donald said? Or
Definitely, yes, because this is something that we struggle, I think, in Europe and in Finland especially, that there is no equity in the healthcare system at the moment. There are a lot of barriers and a lot of built-in structures that sort of what am I trying to say, that blocks, yes, prevents people from getting the care that they need. So that is what we strive to do, is to break the barriers and try to get the equity to blossom.
And it seems that our participants are shy in the chat. Perhaps having the name to be seen there is a little maybe nerve-wracking, since we don't know each other, which is understandable. But if you do have any questions to any of our speakers, you can be in touch with them. Or if any of our speakers have any questions to each other, you have a moment to ask them now. But I just read this comment that has come into the chat. The best knowledge is the most acceptable, effective, translatable for promoting equitable change, right? Great talk. But maybe a moment if any of our speakers had a question for each other before we move to wrapping up. Thank you, Carolina, and thank you, Donald, and we'll thank Niila. So we have a couple more minutes left of this webinar. I'd like to thank all our speakers for your insights and teasers into the topic of participatory research in action. And I'm looking forward to deep diving deeper into the theme further, and hopefully we'll be seeing some talks or workshops around this topic in the European Public Health Conference in November. Today, we really looked into participatory research, and I feel like collaboration and working together rose strongly, as well as changing power structures, thinking of ways of promoting participatory, but also accessibility and inclusion, and also building trust, so that we can thrive from our diverse populations and move forward from equality to equity and liberation. And I'd also like to thank all of our attendees for your interest on this webinar, and let's continue the discussion, and hopefully we meet many of you face-to-face in Helsinki in November. And we will be having the recording of the webinar on the EPH website. And I'd like to do a couple of announcements of further events. So on Friday, the 6th of June, we will be continuing with this webinar series, and we will be asking, why is health not, parentheses, yet taken into account in all policies? The date of the webinar and more details will be on the EPH website. It will be organized with the WHO Collaborating Center at Tampere University, working together with Cancer Society, Finland, EUFA, and the Global Network for Health in All Policies. And also in terms of the European Public Health Conference in November, the pre-conference schedules, the pre-conferences have been announced, and I'd like to note that the European Public Health Migrant Conference pre-conference will cover Indigenous, Sami people, and climate change. So stay tuned for more on that topic. Thank you very much for everybody that joined in today. Thank you for our wonderful speakers, and thank you to our organizers, Hanna-Mari Kuusio and Riikka Rossi. My name is Saida Mäki-Penttilä, and it's been great to be your moderator for this webinar.